I'm just going to let everyone kind of trickle in. Maybe start now as people are getting in. Welcome everyone again. I'm Tad Fentinano. I'm one of the neurologists here in Ottawa, and it's my pleasure on behalf of the Canadian Epilepsy Teaching Network today to introduce Dr. Josephson, who will be speaking on outcomes in epilepsy surgery. Dr. Josephson is an associate professor of neurology and a clinician scientist in the Department of Clinical Neurosciences and the Hotchkiss Brain Institute, as well as the O'Brien Institute for Public Health in Calgary. Major interests for his research rely on big data, basically the application and study of outcomes really in epilepsy when looking at large linked electroclinical health records. He has additional interests also in the use of these data sources for precision medicine purposes, and we're very pleased to have him here. Dr. Josephson, thank you for joining us.
Thank you. It's an absolute honor to be here, and I'm very happy to be able to have the invitation to give rounds today. So I'll just share my screen. Can everyone see the slides there, I hope?
Yes.
Excellent. Yeah. So I have the honor today of talking about how to assess the outcomes of epilepsy surgery. I'll get into it in a little bit, but I think it ends up being a bit of the Sam Weave show. So I'm not sure if he's here. I'll probably be referencing a lot of the work that he's done over the years. Just to start, these are my disclosures with grants and research support and bureau and honoraria that are unrelated to the talk I'll be giving today. So what I'm hoping to convey to people today is to recognize that epilepsies and seizures are highly heterogeneous, and therefore this complicates the assessment often of surgical outcomes. To recognize that seizure freedom is clearly the obvious goal that we usually have in mind, but evaluation of seizure outcomes following surgery is actually far more nuanced than just freedom alone. And to recognize the need for validated questionnaires, common data elements, and core outcome sets to really comprehensively understand surgical satisfaction from epilepsy operations. And this is important because it's a common problem that we see. So I think in the classic paper by Colin and Brody's, we know if you have 100 people in front of you with a first presentation of epilepsy, we would expect about 47 of them to be seizure-free after the first drug, about 13 after their second drug, and then probably about 4 with their third or additional drugs after that. So that means that of the 100 that present to us, about 66 or about 33 of those are going to be drug resistant and therefore be potentially surgical candidates. Now, this is a systematic review that I was involved with Mark Kieser a few years ago, looking at the prevalence of drug-resistant epilepsy. It does vary by setting. So again, it's a busy slide here, but as you can see in population and community-based settings, it's probably somewhere a little bit lower. It's probably somewhere between about 10 to 20%. But if we look at clinic-based settings, where a lot of us work in specialty clinics, that prevalence could be up to about 36%. So this is important. This is a large proportion of patients that can potentially be candidates for epilepsy surgery. So this is why we convened an ILAE commission a few years ago on consensus recommendations for referral. And probably unsurprisingly, virtually every scenario we gave them resulted in referral to a comprehensive epilepsy program. In fact, even in cases where it's been less than 6 months and failed 2 anti-seizure medications, the consensus was that patient should still be referred immediately for consideration, potentially for surgery. Cases where there was the consensus was not reached, but the majority did still recommend referral, was even in cases of non-adherence to anti-seizure medications. And particularly germane to this topic would be failure of an adequate trial of one anti-seizure medication with a potential epileptogenic lesion. And really about the only scenarios in which referral was probably where people agreed to not refer might be failure of an adequate trial of one ASM or recreational drug use, drug-resistant epilepsy not adherent to therapy. So really what it comes down to is virtually every scenario the ILE is advocating for referral to surgical centers. Now, of course, this goes beyond surgery. We could talk about medications, a ketogenic diet. But as you can see here, for the vast majority of these patients, what the ILE would recommend is referral for consideration for surgery, which is something that we're going to be hopefully seeing more of as we advocate for this patient population. Now, as I mentioned, this becomes a bit difficult to really ascertain what people want. Part of it comes down to epilepsy types. So as we know, according to the ILE classification, we can have focal onset, we can have generalized onset, we can have combined generalized and focal onsets, and unknown. And all of these would actually influence a patient's perceptions and their expectations after surgery. So epilepsy type does matter. Similarly, if we look at the expanded classification of seizures from the ILE in 2017, they matter too. So a patient who has only ever experienced focal aware seizures might see their epilepsy and may have expectations after surgery that slightly varies from somebody whose seizures impair their awareness, or those that have frequent bilateral tonic-clonic seizures and experience injuries from their seizures. So as you can see, based on the epilepsy and the seizure types, this might influence how a patient perceives and how a physician perceives the approach to epilepsy surgery. And again, just as a classic example here, so we might have a very simple case, and I put that in quotes. We don't see it quite as much, say, for instance, anymore, but you might have a patient that comes in, they have drug-resistant epilepsy, and they have left-sided hippocampal sclerosis. They have a clear onset left temporal seizures that we may see, and their neuropsychological evaluation may be consistent with the left temporal onset as well. If the semiology is also consistent with the left temporal onset, then this patient may be an excellent candidate for epilepsy surgery, with what I would consider nowadays to be a relatively basic workup. So this patient undergoes a fairly straightforward workup with only scalp EEG. And as you can see here, then we start to tell them, well, if you have a temporal lobe onset, then we know for randomized controlled trials that you have anywhere from 60% or perhaps even higher chance of being free from seizures that impair awareness, with numbers needed to treat of 2 and 3 for freedom from seizures that impair awareness or any seizures. So this patient may have very high expectations for that surgery. They may think that there's an exceedingly high chance that they may be seizure free, as have a very simple operation and be off medications at the end. Likewise, we do know, importantly, and we'll get into this a little bit later, part of this randomized controlled trial that was run by Dr. Lee definitely showed that as well. By those that underwent surgery, there were benefits in terms of quality of life and in terms of employment and scholastic performance after surgery. So you can see this patient might be highly motivated and have very high expectations for surgery. We may, though, run into a more complicated picture. We admit somebody to our seizure monitoring unit. They don't have a lesion on their MRI, or they may have discordant data. So under these circumstances, we may require more tests like ictal or subtraction SPECT scans, PET scans, stereotactic EEG. As you can see, that might then influence your patient's expectations. A far more complicated workup may lead them feeling a little bit more pessimistic about what the outcome could be and a little bit more worried and anxious about whether they will actually achieve seizure freedom. We know that from extratemporal epilepsies, and so a lot of these patients will have extratemporal epilepsy. So in a systematic review done by Jose Zentino back in the day, what they did was reviewing all studies available in the literature as of 2005. The chance of being seizure-free after a temporal lobe operation was about 66%. But if we look at extratemporal operations, we're now going down to about 30 to 50% chance of seizure freedom, depending on a properly selected patient. Similarly, in large centers where patients undergo stereotactic EEG for extratemporal epilepsies, we can see that on average, perhaps about 38% of these will be seizure-free. Just over 50% will have rare disabling seizures or be seizure-free. So again, we're communicating to this patient a slightly different outcome that we expect from that surgery when it comes to seizure freedom. And again, that may influence that patient's expectations and desire to undergo surgery. Again, we might even end up in a situation that's even less straightforward. So we might have patients where we find have generalized onset seizures or widespread more than 2 seizure onset zones, or their seizure onset zone may be singular, but in an eloquent cortex. So therefore, this limits our surgical options. That doesn't mean that we can't still do surgery. So we do know, for instance, maybe we could target particular seizure types. So a complete versus a partial corpus callosotomy has a greater odds of rendering a patient seizure free from atonic or tonic seizures. Same thing with idiopathic epilepsy etiologies. So again, we do know that a corpus callosotomy, if we are looking to target a specific seizure type, could be effective. Likewise, disconnection surgeries in the properly selected patient can be very effective as well, especially if we sever connections with the anterior thalamic nucleus, or the frontal striatal projections can actually result in good seizure outcomes in properly selected patients. Likewise, if resection is not an option, there is neurostimulation. So we can look at vagal nerve stimulators, deep brain stimulators, we can look at responsive neurostimulation. And so ultimately what we know is that, yes, there are potentially other options. But typically for this scenario, we're not often talking seizure freedom quite as much. We're either talking about freedom from a specific seizure type or a reduction in seizure frequency, which again, I think it becomes quite inherent then at that point that this patient's expectations and perceptions of the surgery could be very different than someone we're offering a straightforward temporal resection or potentially an extratemporal resection where the chances of seizure freedom could be much higher. So to summarize that aspect of it, we know epilepsy is heterogeneous. There's a multitude of surgical procedures that exist. So really then, when we're evaluating the outcome, we need to do this in a very patient-centered approach. And so really when it comes to looking at seizure outcomes, we need to be asking the questions, what is important to measure from our as a clinicians or healthcare workers' perspective? What is important to measure from a patient's perspective? What are the best tools that we can use to measure these outcomes? When should we be measuring these outcomes and how often? And how can such measures fit into clinic? So are there ways that we can efficiently put them into clinic so that we have effective means of determining whether a patient is happy with their surgery or not? So, as I alluded to at the beginning of this talk, seizure freedom. This really obviously is usually our primary goal. But it is deceptively complex when we're looking at as an outcome from epilepsy surgery. So this is a very interesting study done back in 2007, looking at a video telemetry unit. What they did was they identified all patients that are all seizures that the patient had, and then asked the patient how many of those were recognized. And what's interesting was up to about over half of the seizures the patients experienced were actually undocumented. They had no idea that they actually experienced that seizure. And that if you extrapolated that to a monthly seizure frequency, they would perhaps, the average monthly seizure frequency in this patient population on their seizure monitoring unit was about 28 seizures per month. On average, the expectation of this was that the patient would maybe recognize 7 of those 28. And this was equally prevalent throughout those with focal aware, focal impaired awareness, or bilateral tonic-clonic seizures. So even bilateral tonic-clonic seizures were missed in about 40% of patients. So again, they may come to us after an operation and say they're seizure-free, but there may be missed or undocumented seizures. They may not actually be seizure-free. There are also natural variations in seizure cycles. So in those that have had a responsive neurostimulation placed, what we've been able to do is look at the electrographic seizures that were produced, the electroclinical seizures that were produced and detected by the RNS, as well as seizure diaries. And it's not uncommon to see daily, circadian, multidian, but also circannual distribution of seizures. So if we operate on this patient in February, maybe, and then we evaluate them in December, we may say they have a really good response to surgery, when in reality, it seems that their seizures do tend to cluster in the spring of the year when they have large phase locking values here. And so we need to understand that it's a little bit more complex. And sometimes we either have different patterns of seizures or seizures themselves, maybe the patients may be oblivious to this, making it actually a bit more difficult to determine whether that patient is truly seizure-free after their operation. But say, for instance, we know with a great degree of certainty whether that patient is seizure-free. We know that they are highly reliable. They have excellent eyewitnesses, and they can tell us with certainty they were seizure-free. Well, the next thing that complicates things is how long is long enough? So where are the beginnings and the endings of determining whether a patient is seizure-free? So in terms of how long is long enough, we can sometimes, in some senses, extrapolate from how the ILE defines drug-responsive epilepsy. So the way that it's currently defined is that you achieve seizure freedom for 1 year or 3 times the longest previous or pre-intervention interseizure interval, whatever is longer. So if the patient has had their longest pre-surgical interseizure interval was about 3 months, we would have to wait 1 year to say that they have or absolutely have responded to the intervention. What becomes more complex is if their previous or their pre-surgical interseizure interval was about 1 year, then arguably we would have to wait about 3 years to say that they actually have responded to the intervention. So that's how long we potentially could wait. But also, when did we begin to assess for seizure freedom? So again, there's a plethora of studies out there that tend to ignore early postoperative seizures, anything that happens within the first 30 days. This is perhaps, I would argue, insufficient. So as we do know, early postoperative seizures do matter. And it doesn't matter when within that first 30 days it happens. What you can see is the equal proportions, irrespective of it was day 0 to 1, up to day 22 to 28. There was a significant proportion of patients that went on to develop late onset seizures. And overall, as I mentioned, it didn't matter. The risk ratio for having seizures on day 0 to 1 versus day 22 to 28 was fairly equal. So the very presence of early postoperative seizures is important to take into consideration. Again, as we can see this on the Kaplan-Meier analysis of those that had postoperative seizures within 28 days, the vast majority of those patients went on to develop to continue to have seizures outside of that interval as compared to those that did not. So arguably, timing also matters. We need to understand how long we need to wait, and arguably, we should be recording any seizures from the minute that operation has ended. Also, then, is absolute versus what I'll refer to as relative seizure freedom. So, say, for instance, we have waited the duration, there were no preoperative seizures, and then we waited a long time, and we're able to say that that patient is seizure free. Well, what effect does that have on their quality of life? Well, interestingly, there's some data that has been produced that 100% seizure freedom in patients that undergo resective surgery is what we need to aim for. So when looking at overall quality of life on a number of different scales, as well as mental health and physical health, what you can see here is those that had 100%, i.e. were seizure free, were significantly different than those that had anywhere from a 0 to even a 99% reduction in their seizures. So anywhere from a reduction was significantly lower than a patient that was seizure-free after an operation, statistically significant here. So again, really emphasizing that seizure freedom is critical for quality of life in people that undergo epilepsy surgery. Having said that, this is not a black or white scenario. So sometimes our palliative surgeries can matter. As I talked about previously, we can look at things like a corpus callosotomy to potentially remove drop attacks. And in these patients, there is an association. So if you decrease the drop attack frequency, you get significant benefits in terms of cognition, and importantly, in both the patient's and the parent's satisfaction with surgical outcomes. So in some patients, yes, 100% seizure reduction is absolutely critical. Any less than that interferes with quality of life. Conversely, though, in correctly selected patients, arguably even a reduction in seizure frequency can have important effects. So this is something we need to be counseling patients about and thinking about in advance of an operation. If patients continue to have seizures, then the other thing we need to take into account is the seizure severity. Now, there are a number of scales that are available to look at seizure severity. These include the National Hospital Seizure Severity Scale, the Hague Seizure Severity Scale, and the VA scale. Now, concerns remain regarding limited scopes, arbitrary scoring, lack of ability to threshold what is meaningful versus what is not in terms of degrees of severity. There's inter-rater recall, inter-rater reliability, recall bias, and we'll get into later response shifts. So these probably aren't necessarily ready for rolling out in the real world. But extracting from them, we start to get an idea of if we can get rid of some of these symptoms, a patient may be more satisfied with their outcome, even despite the fact that their seizures are occurring. Some of the severity symptoms that patients have identified include daytime seizures, a lack of warning or inability to fight off the seizures, a lack of control over their seizures, a loss of awareness, conspicuous seizure activity, and accidents and injuries during seizures were, of course, something that was very dismaying to a patient. Incontinence during a seizure, longer seizure durations, post-ictal symptoms and longer post-ictal symptoms, as well as seizure clustering and interference with daily living. So even if we can't make a patient seizure-free, arguably if we look at seizure severity or trying to reduce seizure severity, that could also have an important impact on how the patient does over the long run and how they perceive their own epilepsy surgery outcomes. So with this in mind, of course, we have tried to amalgamate that information into a number of different outcome scales. The two prominent ones that we use are the ILE outcome scale and the Angle outcome scale. Just a few notes of interest. An ILE class 1 is technically completely seizure-free, as opposed to an Engel class 1, which is free of disabling seizures. So for that patient that's completely seizure-free, it would technically have to be an Engel 1A for that. Now, both of these are, of course, referencing a preoperative baseline that was usually arbitrarily defined. So for the rest of these, when we're looking at the rest of these outcomes here. Interestingly, there is some differences. Some of the ILE outcomes require at least 1 year of follow-up, as opposed to the Engel scales, which some of them will require at least 2 years of follow-up before we can actually give them an Engel outcome score here. And likewise, there's a number of arbitrary concepts that are brought into this. So in essence, the Engel outcome scale has no worthwhile improvement. They do talk about seizures worsening, whereas the ILE scale even tries to quantify the degree of worsening. So more than 100%. So they really do actually have an independent area on the seizures have in fact worsened after the operation. So again, there are some nuances to these scales and how you use them, both in clinical practice as well as in the research world. But we do know that these two scales are trying to take into account some of the aspects that we just talked about, including seizure freedom, reductions in frequency, timing of assessments, and in terms of the severity of the seizures themselves. So now that's the reason why we're also now perhaps trying to look at other potential outcomes, like time to the nth seizure. So this is often used in randomized controlled trials. But what you'll often do, again, is have an arbitrary pre-operative or pre-medication, pre-RCT seizure frequency or seizure count. And then you want to see how long it takes the patient to get to that point after the intervention. So if this patient had 6 seizures over 1 month prior to the intervention, they have now had 1, 2, 3, 4, 5, 6 as of day 48. So they've had a 38% reduction in the frequency of their seizures. Over the 3 months of this RCT, if they wait the full 12 weeks, they've had 8 over the 12 weeks, so about a 56% reduction in terms of the seizure frequency. So again, this is another way that we can assess to show that our operation may have had some impact, at least on reducing the seizure frequency. Now, this does have some issues. Of course, cycling and clusters do matter. So you see some clusters here and here. So that could influence the time to the outcome. Sometimes with inaccurate diaries and low seizure counts, it makes it a little bit more difficult to apply this type of an outcome. But when we're actually maybe looking at seizure outcomes from future randomized controlled trials, this may limit the duration of placebo-controlled observation for adverse events as well, because we can then quickly establish an outcome rather than waiting for a pre-specified period of time of seizure freedom. So I just want to make sure that that's on everyone's radar, that this is, although not as commonly used, it is an outcome measure that in some respects is becoming a little bit more interesting nowadays, especially as we're looking at more randomized controlled trials. Of course, that's seizure freedom. So patients are going to want to know both what the benefits and the risks are. So it's really important that we also do not ignore complications from surgery. So this was a systematic review done by Walter Hader here out of Calgary back in 2013, looking at the literature for reporting complications from epilepsy surgery. So by resection, temporal, extratemporals, they were essentially grouped together and stratified. What we found was that minor medical complications, which were defined as neurological deficits that resolved within 3 months of the operation or were considered minor by the patient, occurred in about 5%. And that was relatively equal between those that underwent temporal and extratemporal operations. This is in contrast to major medical complications lasting more than 3 months or considered severe by the patient. This was present in about 1.5% of operations and was, again, relatively equally distributed between those that underwent temporal and extratemporal operations. But the problem is the literature is actually relatively biased. And so what they found in this systematic review was that up to 15% of studies failed to report surgical complications. So again, everyone's hyper-focused on seizure outcomes and forget the idea that there can be complications. There is significant heterogeneity in terms of the method of determining whether complications had occurred, the timing of the complications, and the rigor for which they looked for complications varied. There are also some difficulties in determining what is a complication. So if they were imaged after the operation and they had a quote unquote asymptomatic bleed, so that had no clinical effects, was that really a complication of the surgery or not? Now, interestingly, we can leverage administrative data to look at this. So this was a really interesting study done by John Ralston back in 2016, where what they did was they combined the American College of Surgeons database on complications, as well as the Centers for Medicare and Medicaid databases to identify patients with epilepsy. And it found, in fact, complications occurring within 30 days of an epilepsy surgery could actually be as high as 17.9%. And perhaps, concerningly, but maybe not alarmingly, but concerningly, actually up to 3.4% of patients had died if you look at administrative data within 30 days of that. So if you humor me for a minute in terms of my digression, I just want to make sure that we don't get too concerned about this, because actually long-term premature mortality does decrease from epilepsy surgery. So this is an interesting paper that was just published by Christina Malmgren's group, looking at long-term mortality following operations. And in those that were considered for an operation, for the patients that actually underwent the operation, their long-term mortality was dropped by about 33%. So even though there is a risk of mortality from the operation, this is easily trumped for the long-term benefits of mortality. In those that did die, some significant hazards were obviously, as you would expect, related to age, seizure frequency as well, and actually, interestingly, living alone at last follow-up. So that's just a little bit of a digression to say, although yes, death might be a little bit more common than we were expecting through administrative data, clearly the long-term benefits are important here. But when it comes to surgical complications, so again, we've talked about seizure freedom outcomes, but it is important to understand that surgical complications matter. And we could probably take some advice from the British Surgical Society, where they have 7 elements of good monitoring system using standardized definitions and sufficiently long follow-up, establishing adequate populations using as the denominator to calculate the incidence of these complications, capturing data as soon as possible using dedicated and trained staff, including important risk factors for specific complications, managing data using adequate data processes, so again, ensuring confidentiality, reporting outcomes and feedback in a timely and also user-friendly manner, and agreeing on procedures for ongoing surveillance after discharge to make sure complications aren't missed in that setting. And that is something that we probably need to do better as an epilepsy group moving forward. So we've talked about seizure outcomes, we've talked about complications, but also neuropsychology matters. And it's interesting because I like this paper by Sarah Wilson that really conceptualizes someone's neuropsychology into fixed factors, factors related to the course of the disease, and remedial factors. And this becomes important when it comes to surgical outcomes, because we could use fixed factors in the course of the disease to actually try to ascertain what the risk is from an operation. So if the surgical or if the seizure or epileptogenic lesion is in an area of the brain that has caused a neuropsychological deficit, that patient might ironically have a lower risk of an operation. If that lesion that we're trying to operate on hasn't affected the neuropsychology, but is in a location of the brain that is quite elegant for that, then there could be a higher risk. But equally, due to remedial factors, we may even benefit the patient neuropsychologically afterwards. If we reduce medications, if we reduce interictal and electrographic seizure burden with better seizure control, in some respects, we may actually be able to improve neuropsychological outcomes. So again, neuropsychology is exquisitely important when assessing surgical outcomes. And of course, as we know, there are now recommendations for the core cognitive and psychological domains that we should be assessing preoperatively and postoperatively. And this is something that we should be doing worldwide to ensure that we not only counsel the patients appropriately in terms of benefits and risks, but we can plan then for the outcome after a surgery if the risks are considered to be high. And this is important because, again, this was from Jerome Engel's paper that was a follow-up on the earlier randomized controlled trial from Sam Weeb, looking at early temporal lobe resections. And as expected, auditory delayed recall and Boston naming tests, so auditory and verbal memory, is significantly impaired, especially in those patients that undergo temporal lobe operations. So we do know that we need to prepare and counsel a patient for this. This is an important outcome. A patient needs to know if their auditory, verbal, or visual memories are going to be affected by that operation. So this is critically important in terms of outcome assessments for patients as well. Similar to that is postoperative psychiatric issues too. So going beyond neuropsychology, we also need to think psychiatrically how that patient's doing after an operation. So in terms of patients that undergo resective operations, interestingly, there is a significant reduction in terms of the degrees of depression and anxiety that occur after operations. And in those that continue to have depression and anxiety, almost half of them had preoperative depression and anxiety. So, in other words, then, we may have a positive effect in terms of their mood. Now, having said that, there are some caveats that, as you can see here, at least for depression, for instance, preoperatively about 22%, postoperatively about 9% reported depression. But interestingly, of those that had depression preoperatively, about 52% had a moderate depression, whereas 55% had a severe depression afterwards. So even though there is a reduction in depression, in some cases, the depression could get worse. Some of this may relate to a lack of seizure freedom, and this is why we should be assessing this for all of our patients. So moderate severe depression was present in about 8.2% of those that had 2 years of seizure freedom. It was present in almost 18% of those that were not seizure-free. A similar trend was noted for moderate to severe anxiety, where those that weren't seizure-free did have higher rates of that after the operation. So we do know that many psychiatric disorders are common in epilepsy. So, up to 23% of patients will have depression, anxiety, up to 23 to 24% will have anxiety. Psychosis is common in up to 5%, as well as personality disorders, suicidality, and so on. These are very common in patients with epilepsy. And as I hope I showed you through the previous slide, we can sometimes unfortunately exacerbate pre-existing condition, and they can sometimes arrive de novo following surgery. So there are now recommendations that perhaps psychiatric assessments should be routine in both pre and post-operative assessments in terms of counseling and outcomes. Proper psychiatric assessments can look at lifetime history of psychiatric disease. They can look at the family history of psychiatric disease. And I think quite importantly, they can evaluate patient and family expectations and have clear discussions on the consequences of seizure freedom, the expected socioeconomic changes, family dynamics, and so on and so forth. And why is this important? This is exceptionally important because of the burden of normalcy or normality. And this was a fascinating concept that, again, was raised a number of years ago. So the idea is that there are probably 3 precursory conditions: the chronic illness of the epilepsy, a sense of disablement that somebody has from their epilepsy, and they're now being offered a chance for a dramatic cure. Their expectations will then influence how they perceive the outcome. And if certain expectations are present, they may develop a syndrome, which has been referred to as the burden of normalcy. So this has essentially 4 core features: some psychological features in terms of a sense of cure. They may grieve for the fact that they no longer have epilepsy. They may have to prove to others now that they can do jobs that maybe they weren't necessarily prepared for. Someone may say, well, if you want this job, we need proof that you are seizure-free and so on. They now have increased expectations, but along with that, a lack of excuses. Well, you're no longer seizure-free, so why aren't you working? Why aren't you driving? And making out and grieving for the lost years that they failed to receive education and vocational experience to prepare themselves. As we alluded to, there are a number of affective features as well. So mood elevations, but also depression can occur afterwards. There are behavioral features as well. There may be excessive activity, increased sex drive, and shirking of behaviors as well. So in other words, they may become more active and have more expectations, or they may develop somatic complaints because they weren't prepared for the fact that they no longer have seizures, as well as sociological features. So again, there's some restructuring of family dynamics when you no longer have seizures. Hidden agendas may emerge. There's new vocational horizons, which can be intimidating. And also they may have to learn new social skills as they can now get out and perhaps socialize and be more involved in the world so that they no longer have seizures at that point. And what's interesting is that you could then perform very sophisticated multivariable analyses. What you can essentially do is block the impact that seizure freedom has on a number of outcomes. So if we control for the pathophysiological indicator, which is here seizure frequency, we block its path to perceived success. What was found was that treatment expectations, as expected here, exerted a significant effect on the perceived success of that operation, independent of the seizure frequency and seizure freedom afterward. Again, reinforcing this idea of the burden of normalcy and how those expectations influence that. And this was an interesting quote from the initial paper, in which they say this finding demonstrates the importance of including patient expectations in measuring treatment outcome. It contrasts with more traditional approaches in which a patient's view of an intervention has often thought to be able to distort the objectivity and the outcomes, when in fact the findings with a burden of normalcy suggest that patient expectations not only should be, but probably have to be included as an important factor in research design moving forward. So again, I'm hopefully emphasizing to you again, while seizure freedom is important, this is also important. It is another aspect we need to be considering when we're looking at seizure outcomes from surgery. So how is this influenced? Well, there are a number of different things. I mean, as I alluded to in the previous slide, now patients are expected to perhaps study, to work, they lose their benefits, they're expected to drive, they wonder whether they still have a chronic illness or not. Some may want to come off anti-seizure medications or may see the fact that they're still on anti-seizure medications, that this may be a failure. And there could be personality and psychosocial changes. So when we do sophisticated analyses into those that actually have a burden of normalcy versus those that don't, what has been found is that those that had preoperative high levels of positive reinterpretation and growth, as we can see here, or ability to accept situations in which they are currently ensconced in, actually had better quality of life and reduced depression. So they had better ways of coping with their epilepsy preoperatively, and they had better ways of coping with the fact that they were seizure-free postoperatively. Likewise, those that had better social functioning and had less role limitations imposed upon themselves from an emotional, memory, and physical aspect had less anxiety and less depression afterward. So again, this is why it's important to counsel and to evaluate for this in advance of the operation, so we can know whether this may be a problem after the operation, and we can certainly assess for it after the operation as well. So this then brings us together to, is there a way to look at everything I just talked about? So seizure freedom, complications from surgery, psychosocial outcomes, psychiatric outcomes, cognitive outcomes, burden of normalcy. Well, we are now making attempts to do that. And this follows under the rubric of treatment satisfaction. So an overall concept of satisfaction, as it is implied in medicine, is associated with better health state utilities, better quality of life, and better adherence to treatments. And epilepsy surgery satisfaction is a way of capturing different aspects of quality of life that really encompasses everything we just talked about. So this was an initiative that was led out of Canada, where we actually developed what was called the Epilepsy Surgery Satisfaction Questionnaire. Initially, we had focus groups to identify themes that were relevant to patients in terms of the epilepsy surgery. We had a Delphi process from experts and clinicians and healthcare workers to help refine the items. It ended up in 12 themes with 31 items, including things like adverse effects, medical care, and rehabilitation. Now, this is a little bit burdensome to give to patients, so this was streamlined down into what we call the ESSQ-19. To do this, we then abbreviated the questionnaire, as I mentioned, administering it about 6 weeks apart in about 230 patients that were aged 18 years or older. So this essentially refers to adult patients who had resective or disconnective surgery over 1 year earlier to avoid response shifts, which is something I'm going to get into a little bit later. This was done at multiple centers and has been translated to English, French, Swedish, and a number of other languages. And we're able to correlate this with a number of other instruments that pertain to quality of life, depression, self-assessed epilepsy severity and disability, as well as treatment satisfaction. And this is what happened. We're able to distill it down into 19 items that cover areas such as seizure control, psychosocial functioning, surgical complications, recovery from surgery. So this is 18 here. And then one global item that just asks, taking into account all aspects of your epilepsy surgery, how satisfied or dissatisfied are you? These have excellent internal reliability as well as test and retest reliability. And this becomes really important to have these scales because it then helps us refine and understand why a patient perceives their surgery as a success or not. In order to do this, we actually use some machine learning. I'm not going to get into this in a lot of details, but really the idea here is it's very similar to linear regression, where we're trying to minimize the difference between an observed or predicted outcome. What we do with what's called support factor regression is that we do the same thing. What we do is we select a number of patients, we develop a regression line, and then what we do is we gradually increase what we call the error margin, because the idea here is this is probably underfitted. By increasing this error margin, we include more and more outlier patients. And as a result of that, we may get a more accurate regression analysis of what drives satisfaction. But the more we increase the error margins, the more likely we are to overfit the model. So we penalize it by overextending these error margins. What we do is we try to find a balance between overfitting and underfitting by developing a regression line. The regression line, the outcome here would be epilepsy surgery satisfaction according to the ESSQ-19 scale, which varies from 0 to 100. So if we apply this type of machine learning to that, what we'll see is the following. To begin, actually, what's interesting is that of the 201 patients that had full data, most were relatively satisfied with their surgery. So again, from 0 to 100, the median score was 68, with an interquartile range of about 59 to 75. So the majority of the patients were quite satisfied when they looked back on their epilepsy surgery. If we rank according to the standardized coefficients, what was associated with satisfaction, what we see is a myriad of conditions. So self-perceived epilepsy disability after the operation is a huge component of how satisfied they are. Age and quality of life are also major components. Then we get into seizure freedom. This is a big component for patients in terms of determining satisfaction. But quite similar to this actually is yearly frequency of seizures. So even minimizing the number of seizures they have per year does have a significant impact on how satisfied they were with their operation. And we can quantify that now. Each one medication reduction in the post-operative anti-seizure medications was associated with higher satisfaction. Patients want to come off their medications, and ability to come off their medication was associated with higher satisfaction. We could also look at a number of psychosocial aspects with this as well. And overall, developing prediction models, we can see preliminary attempts at this are relatively conservative. They don't tend to, the orange is the predicted outcome, the blue is the actual outcome. So as you can see, it's relatively conservative. It doesn't tend to model the outliers quite as well, but we can begin to model what we think that, how we think that patient will be satisfied with their surgery and extract the features that derive that satisfaction. So really then moving forward, in order to amalgamate all of this into one unified way of doing this, we should be looking at common data elements, which really are the minimum data set upon which all other data could be collected, depending on the study. So here we would have a minimum data set. If we're looking at surgery, we can basically add surgical variables to this, as well as core outcome sets, which is essentially my talk right now, is going through what are the core outcomes that patients and physicians need to know and should be included in all studies moving forward with standardized ways of measuring them. So there is work on this right now. NINDS is looking at common data elements. They have general common data elements that should be associated with every neurological disease. They also look at epilepsy. Experts have identified 9 core domains that we should be asking about for essentially all epilepsy studies. So really it comes down to our core elements. Then we have our disease elements here. So all of the epilepsy specific questions that we should be asking, as well as for standards on how to do it and recommendations on validated scales to measure that. And then we could supplement that with seizure specific or outcome specific measures related to the epilepsy surgery as well. So this is something that we should be doing moving forward to homogenize our studies looking at surgical outcomes. Likewise, efforts are currently ongoing right now for core outcome sets. Again, we kind of talked about this. So we're hoping that EPSET will be published by next year. They're looking at developing core outcome sets. But as I'm hoping you could derive from the talk we just mentioned, core outcome sets will probably include seizures, satisfaction with surgery, quality of life, mood, working, ability to drive. By doing this, we can then select measures that measure this. And then what we can do is then refine those instruments to have a core set of outcomes that should be asked at every single surgical study moving forward, and ideally, potentially, in clinics to actually assess outcomes. So the only wrench in that, of course, is what meaning does this have? What change is important? Because what's interesting is that small mean changes may conceal important treatment effects. So if you look at quality of life after an operation, if the mean preoperative quality of life was 50, and then after the operation, 4 patients went to 0 and 4 patients went to 100, well, the mean's still the same, but it's masking important changes. Likewise, large mean changes after an operation can be misleading. There may be one or two outliers that are driving that. So what's really important moving forward is we do know minimal clinically important differences for health-related quality of life in epilepsy, but we'll probably have to do this for many of the other scales we just talked about. The idea here is we can ask patients to rate their health-related quality of life on a Likert scale. And on this Likert scale, you can see here, what I felt was between 1 to 2 is really no positive change after an operation quality of life. Between 2 to 3 is a small change. Between 4 to 5 is a moderate change. Between 6 to 7 is a large change. So by identifying these patients, we can look at their mean quality of life according to the quality at each of these stages. We can develop a regression line that does this. We do know that on health-related quality of life, a mean change, a change of about 3 is clinically important. So if we add 3 into a regression model here, use the regression coefficient here, we can identify that 10.14 is a minimally clinical important change on quality of life. So then we know moving forward, we would want to see a change in quality of life of at least 10 or more to say that that was clinically important. So if a patient's quality of life moves from a 50 to a 55 after an operation, arguably that may not be significant. If it moves from a 50 to a 62 or a 63, that is important and can influence how a patient sees their operation. So this is something, even though I've talked about having these outcome sets, we need to know how to use them and what change in these outcome sets are important. And it behooves us as a group to be able to do this for many other aspects beyond quality of life moving forward. The final wrench is response shift, which is what I mentioned earlier. So you can have multiple different types of response shifts to an operation. So you can have recalibration response shifts. So a patient with new onset epilepsy may initially rate their illness as severe, but over time with coping mechanisms, rate it as milder despite having no change in the epilepsy itself. You can have reprioritization as well. So a patient's values towards their epilepsy may change over time. If they're no longer able to engage in physical activity, they may overemphasize things like mental or social outcomes. And therefore, despite no change in the epilepsy itself, their health-related quality of life could improve, as well as reconceptualization as well. So they may redefine their view of epilepsy. And therefore, over time, despite the fact their epilepsy hasn't changed, you ask their quality of life in 3 or 4 or 5 years, it may be significantly higher, despite the fact that there was no change in the disease itself. And this becomes important when you look at someone's view of their epilepsy surgery over 1 year, 2 years, 3 years, 4 years, 5 years after their surgery. What we can show is that there probably is a response shift. So interestingly, if you ask at baseline right after the operation at 12 months, if you ask a single item question, what's your overall quality of life, there really wasn't much of a change. But in every subset of the quality 31 domains, there was significant increases in each of these subsets 12 months following the operation compared to at baseline, with really no change or very little change in terms of the medical management. There was some change there as well, but quality of life, you could see, significantly changed. And when you do very sophisticated regression models looking at what is driving this, the primary response shifts were actually in social function and seizure worry. So immediately after the operation, patients, and especially before the operation, seizure worry was a major aspect of a patient's quality of life. But this significantly reduced about 12 months after the operation. And this seemed to refocus more on social function. So preoperatively, there wasn't as much worry about social function or concern about social function. 12 months after, there was a reprioritization response shift where social function now became a priority and seizure worry wasn't, which is what we would expect based on what we just talked about from psychological and burden of normalcy outcomes. So even though they may score the same on the health-related quality of life, the way that they view it and the different subsets do actually significantly change, and we need to be aware of that moving forward. And finally, just to kind of end this talk today, I think we also need parents and patients' perspective. Dr. Weeb, so Sam Weeb and I wrote a chapter on this recently for the Updated Angle chapter. And we actually had the joy of working with a patient advocate. And, she brought in very important points of, her view with her child was, will my child walk, talk, learn, and thrive after surgery? She's done a lot of work in this area. I mean, she's concerned about the fact that, at present, there really are very few or no validated pediatric scales for looking at holistically how a pediatric patient is going to do afterward. And there was concerns about proper counseling of parents who requires such knowledge. A number of surveys that were sent out to pediatrics showed that 11% of the physicians didn't discuss surgery, 41% didn't discuss outcome statistics, almost 70% didn't discuss complications. This was a survey done by her group, so the Brain Recovery Project, asking parents what their views were, and about up to almost 40% felt that healthcare workers up to about 40% felt that the healthcare workers are actually knowledgeable about surgery, so 60% didn't. And unfortunately, only 21% believe the healthcare workers and physicians were knowledgeable about functional outcomes after surgery. So we do need to do a better job at that as well. So this is why moving forward, this is what the ILE has been working on, as well as a holistic framework for post-operative recovery. Preoperatively, we need to be counseling. We need to even engage in neuropsychological pre-rehabilitation and looking at other psychological and social supports in advance. We need to identify patients at risk of neuropsychological deficits and the burden of normalcy and optimize support networks. Then afterwards, we need to have a graded approach. Initially after surgery, we may be looking at immediate rehabilitation like physiotherapy and speech therapy, but we should already start addressing health and fitness, return to work, and cognitive remediation. By 3 to 12 months, we can then push forward with more vocational training, psychological and social supports, neuropsychological rehabilitation, really, again, starting looking at returning to driving, study, and training and work. And then after 12 months, there probably does need to be ongoing psychological and social supports that really help with things like family planning and career progression, to again help kind of get beyond the burden of normalcy that we often see in these patients as well. So again, this is why we need to be thinking about this holistically. I'm hoping that I imparted that upon you today. So really, in conclusion, seizure outcomes are deceptively complex after an operation. Focusing only on seizures, I would argue, is insufficient and inadequate. And I would argue, and I hopefully impressed upon everyone today, comprehensive outcome assessments are complex but are necessary. They have to include satisfaction. They must account for response shifts that occur after an operation. And we need to identify meaningful clinical changes so we know that what we're doing is actually having an outcome on that patient's overall quality of life. And that one way that we should do this moving forward would be identifying common data elements and core outcome sets, so we are all collecting the same data in the same fashion, so that we can find ideal ways of intervening to ensure that every aspect of post-surgical care is optimal for that patient. So with that, I'd like to thank you for your attention today. I'd like to thank all my mentors that have helped me throughout my career, and I'd be more than happy to answer any questions they may have. Thanks very much.
Thanks, Dr. Josephson. Is the audio okay, given that it wasn't? Awesome. So a couple of questions for you from our attendees. I guess the first one might be for ERAS in terms of that protocol. Do you know if it's widely used already? It's already considered a standard of care for epilepsy patients post-surgery?
Yeah, I would argue it's probably not widely utilized at this point. It is something else that we need to be thinking about again from a holistic point of view. Absolutely. Yep.
So then another question has to do with your expertise in AI and the fact that, you know, best guess is often what comes into play when we talk about the patients during the surgical conferences and we say, okay, well, you know, we're going to offer you a surgery, but your chances of seizure freedom are this, psychosocial outcomes might be this. Do you feel like there's a realistic machine learning tool or some sort of AI in the near future that can just plug in, you know, all the different patient variables and model the outcome prediction?
So it's funny, if people have been at the World Congress of Neurology a couple of days ago, I gave a talk there, and I kind of alluded to that exact thing. So I think yes and no. I think it's not in the near future. I think there are nomograms and algorithms that are available, and with all due respect to my colleagues that have created these, it's excellent foundation work. But bar none, what they've done is a phenomenal job. But if you look at the AUC, so discrimination, so the ability to say, well, this patient will be seizure-free versus this one won't. Or if you look at calibration, how well is the anticipated or the predicted percentage of seizure freedom actually align with the number of patients that will be seizure-free with that prediction? What we actually did was Colin Klein, I'll give him credit, was the one that did this. He actually had surgical conference rounds in Germany. And as a group, they said, okay, what do clinicians think is going to be the outcome here based on all the information, and used all the available nomograms. In fact, we did better than nomograms. I would hope so. We've done, I'd like to think the last 17 years of my life hasn't been for nothing. So I don't think we're quite there yet in terms of doing that. However, I do think we will be there. And I think this is going to require a lot of data. So that's the reason why I'm really trying to push right now for core data elements, like core outcome sets, because we need to make sure that we have standardized data and a large enough volume in multiple centers to be able to look at this. We probably need higher dimensional data as well. So more raw EEG, MRI, genetics, neuropsychological data, that sort of thing. And I think, with high dimensional data, using huge data sets, yes, we probably will get to a point where we can say yes. But if I'm being very conservative here, I think that is probably 10 years in the horizon. And I think actually, just to plug the Canadian environment, we're probably in a good setting where we could do this. We have a small enough community that gets along really well. The data sharing would actually be fairly easy. I think we can all agree on how we collect our data. I think we can agree on within our public healthcare system data sharing processes. I think we could be a global trendsetter here. And I think that's an excellent point. I think this is something that we should be doing.
Infectious optimism. I love it. So we have another question here. So, I guess maybe not traditionally quoted number, but one quoted number that you often see is that 70% of the time you'll have what you need for a skip surgery just from the pre-surgical evaluation, and really stereo is not necessarily the rule. I would question that in the major, US centers. That's really becoming more the rule than the exception, even just testing out pre-surgical hypotheses. So the question is, if you have, concordant seizure semiology, IEDs, ictal onset, but an MRI negative, and I assume functional imaging means PET positive case, do you skip the patient or do you go to invasive EEG? General question.
Yeah, it's a difficult one. I mean, I would argue in some respects, absolutely, you probably could, depending on the localization. So I would argue, especially in temporal lobe cases, you probably could. So if it's a non-lesional temporal lobe epilepsy, the spec shows anterior temporal, the PET shows hypometabolism, anterior temporal, interictal discharges are all unilateral, and semiology is consistent, the neuropsych is consistent, then yes, you probably could go straight to surgery. I know, and JP, you could probably chip in as well. I know in our center, we argue this all the time about extratemporal cases. And if you have a PET that's concordant with the subtraction spect, an onset within the frontal lobe, would you actually proceed with surgery or not? I would argue in our center, we probably still go stereotactic EEG if it's extratemporal, and I would argue it probably does make sense over the long run. So it's a nuanced question. Again, maybe big data and AI could potentially help long-term down the road for that as well. But temporal lobe, I'm probably a little bit more sort of optimistic about avoiding stereo EEG there. Extratemporal, I'd be a little bit more reluctant, even if everything's concordant. I see concordance of data extratemporal as generating a hypothesis that I would want to confirm with the stereo EEG before proceeding to surgery. But I think that's probably, the Calgary approach if I'm speaking outside school.
Just following your thoughts, Colin, briefly, because we have some other question, but in those cases, we don't use the SEEG as a diagnostic tool, but rather as a helpful tool to delineate and narrow down the resection to make it the smaller possible with better successful rate, and also to confirm that we are not on potential functional brain tissue that is, so brain mapping as well. So in those cases, that's when we use SEEG, even though it's very concordant, everything it's really, really pointing towards a particular area. That's so in case to clarify. But yeah, it's a very interesting proceeding.
I'll make this the last question, Dr. Josephson. Do you find that there's any role for stereotactic EEG in a genetic generalized epilepsy?
The genetic generalized epilepsy, probably not so much. In genetic epilepsies, yes, there is a role, I would argue, depending on the type. I know Colin Martin's on the line. He may not be able to speak, but he'd be a good one to address this. But, I mean, you could argue that tuberous sclerosis, for instance, is a genetic derived epilepsy. It does cause structural lesions as well. And, finding the tumor that's actually causing the epilepsy, I would argue, absolutely has a role there. If we're talking about more like a JME or something like that, then I would argue probably less so. And that's the reason why, as we talked about in the talk a little bit earlier, you kind of shift gears in my mind a little bit about the different types of operations being more like neurostimulation, depending on if you have Lennox-Gastaut or something like that, you may be thinking about things like corpus callosotomies. And that's the reason why, again, what I hope to impress upon people today is that not every seizure surgery is created equal, and therefore you need to understand what those aims of those outcomes are. So, I mean, I think it's important, maybe if I just take a sidetrack, it's a bit of a tangential comment to that, but the ILE Consensus Commission on Referral, one of the reasons why we actually had that consensus was our worry was that people were actually avoiding referral for cases like generalized epilepsies because they said, well, there's no surgical resection option, so why am I ever going to refer them? When in fact, there are a lot of things we could do in terms of VNS. There's corpus callosotomies, disconnection surgeries, these sorts of things that actually can be offered. And so we want to get rid of that sort of myth that if it's not a resective surgery, then don't refer. So I do think this is an important patient population that could benefit from surgery. We may need to kind of refocus how to address those outcomes. We're looking more at seizure reductions, or we're looking at more in how that's going to affect their quality of life. But they can certainly benefit. And this is why we need a holistic view of seizure outcomes, not just the seizure frequency, but if we get rid of drop attacks, that improves their cognition, that improves their attention, that improves their quality of life, that lessens injuries, lessens, the burden on families. That arguably is a very good outcome from surgery, even though they're not technically seizure-free.
Fantastic. Thank you so much, Dr. Josephson. That was an amazing talk. Thanks everyone for joining us. Just a reminder to please complete the feedback and claim your CME. The link is posted in the chats. And looking forward to seeing everyone for our next session next month. Have a great weekend wherever you are.
Excellent.
Thanks, guys. Really
Excellent. Thank you so much, Colin. Have a good day.
Yeah, appreciate it.
Thank you.